Without further ado, it's my pleasure to introduce to you the doctor.
Who? What a great day to start medical school. You are so aberrant as medical students. I don't know one single medical student who relishes coming to a 9 o'clock class. Let's see if I can get my slides on board here. And where's the... I'm a Mac user, so I always get slightly... Oh, F5. All right. Very good. Thank you. So this is very exciting. This is my second year hosting the Menigal Medical School, being the MC, Aging in Medical Science, a mini medical school to prepare you all for life's second half. Me too, actually. So, for those of you who are new, this is what we were like last year. We hope there'll be as much enthusiasm as there was. And here is last year's graduating class. How many of you were in that graduating class? Raise your hands. Wow. I didn't realize how many people stayed back in 1 year. We'll hope more of you will matriculate this year. So this year we have a theme. On the quest for the fountain of youth. I know it's an X-rated or R-rated engraving, but it is an old engraving. Restoring function to the older adult, what medical technology, techniques, and therapies can and can't yet accomplish. So we have a basic theme there. So we have a variety of exciting lectures. We're going to be talking about restoring mood in people who are depressed, new treatments for Parkinson's disease, stem cells for Parkinson's disease, heart disease, and new ways to avoid the cardiac surgeon by new and stenting techniques for people with coronary disease. Renal transplants are no longer for the young. We are seeing and doing renal transplants in people 70 and 75 years old. People who have degenerative eye disease now have new hope for perhaps restoring or prolonging the quality of their vision. And joint replacements, technology has been advancing. I will be talking about hormone therapy and what it can and can't do for the elderly. And Dr. Fitzgerald later this morning will be talking about gerontophobia and issues with the societal fear of aging and prejudice against those of us who are getting older and our own fear of getting older ourselves. So I'd like to thank our sponsors for this year's mini medical school, as in years past, Safe Credit Union, whose booth is up in the back, and I hope you'll visit it, Genentech, the Sierra Health Foundation, and of course our own Department of Internal Medicine, for which Dr. Fitzgerald and I work. And of course, I'd like to thank our volunteers, the mini medical school volunteers, past, present, and future, without whom we couldn't do this, and our mini medical school advisory committee. If there are any members of the advisory committee, would you please stand and introduce yourselves? There's one back there, a couple back there. Another there. There. Thank you. These are very important people. They keep us on the straight and narrow. Thank you. And of course, there would be no mini medical school without you, the students, for your interest, your enthusiasm, your dedication, and your kind donations over the years. So thank you so much. And you all deserve our applause. So Sandy has already given you the main pointers, handouts about handouts. They can be emailed to you, and if you have a printer, print them. Our medical students, despite their $40,000 a year tuition, are now expected to print their own syllabi on their own computers at their own ink expense. You too can do that. And if you want, you can pay a medical student tuition too. It's only $40,000. And of course, if you've got the urge, there's also the surge the Surge 3 building, which you heard about. Bathrooms up there for women, men in the lobby, and then the Surge 3 across the street. So what I'm going to do is, realizing that all of you, let's see, how do I escape? Now I'm going to do this. But realizing that all of you are going to be missing Wait, Wait, Don't Tell Me this morning, and I know how much you like Wait, Wait. How many listen to Wait, Wait? Missed about 3/4 of you. So we're going to have our own limerick challenge this morning. You get 2 of the answers right, and you win my voice in your home answering machine. No way. So, there will be much new knowledge you'll learn, many things that your lives will concern. With Obamacare here, do you curse or you cheer? For I get health care for all, you must rhyme, please. Yearn. Oh, good. Okay, excellent. You are smart, not the mere hoi polloi. We expect that your mind you'll employ. Please absorb all the knowledge from this medical college. Now sit back, pay attention. Absolutely. Very good. Wouldn't that be scary if I suddenly answered your answering machine for you? That would... All right, so here we go. So we're starting out with restoring strength and vitality through hormones, something that Alex Rodriguez is trying to do. But there are facts, fantasies, possibilities, and pitfalls, of which there are many. So I have no financial disclosures or conflict of interest. I am clothed. So as we get older, there are significant changes of body composition which are part of normal aging, but not inevitable aging. Muscle mass drops after the age of 35. Muscle mass in men and women drops about 50%. Fat mass or adipose tissue increases by about the same amount, especially accumulating in the kind of middle section there. And bone mass declines by about 20% from youth to aging. So are these absolutely inevitable? Can they be slowed down? Can we reverse these? So there are a number of changes that go on with these, or consequences of these changes in lean body mass. Strength declines, and people have a harder time doing stuff that they need strength for. People who have, at the age of 65, about 1/4 of men and women have a grip strength that is very low. They might be able to hold a coffee cup, but things are getting hard in heavier things. By 80, 40% have a very low grip strength. People have trouble getting up from a low chair. How many of you are now needing to push off with your hands? Well, that's not necessarily inevitable, but there's an increased risk of falling because of changes in strength and an increased risk of developing frailty and subsequently disability. The increase in body fat that we talked about is accompanied by increased risk factors for cardiovascular disease, like higher cholesterol and triglycerides, and decreased glucotolerance and increased risk of diabetes. And of course, lower bone or bone loss leads to osteoporosis, which can lead to osteoporotic fractures, or what we call fragility fractures. So falling from a standing height can lead to a fracture of the hip, of the wrist, and people just lifting something heavy or stepping off a curb unexpectedly and jarring their spine can lead to a crush of the vertebral body. So people, as they get older, might become stooped. And that can lead to pain and disability. 50% of people who suffer a hip fracture are not ambulatory a year later. Well, I remember a time not long ago, maybe 15 years, when women were routinely prescribed estrogen therapy at the menopause, Premarin, but in the last decade, that practice has gone from embraced to repudiated among health practitioners. But that doesn't mean that estrogen and progesterone don't go down in the aging woman. You can see that as there's a 35% decline from the peak around age 30 or so, 25, to the menopause. But that sort of threshold level at the menopause, when it goes below that, symptoms develop. Progesterone declines even more. So I think most women, if they've gone through the menopause, know what some of the side effects are of losing estrogen. Hair becomes thinner. There are small, not clinically meaningful, but noticeable effects on memory, certainly during the first 5 years, where people feel more forgetful. Loss of estrogen has not been found to be a predictor of developing dementia, has not. But breasts have changes, more fattiness, drooping, flattening, hot flashes, accelerated osteoporosis that speeds up at the menopause, worse cardiovascular risk factors with increased low-density lipoprotein, lowered good cholesterol, the HDL, decreased elasticity in the skin and coarsening and more wrinkling, and then vaginal dryness and shrinkage. So there was a lot of hope with estrogen. I mean, women developed heart disease a decade later than men historically have, and that was thought in part attributable to estrogen. But there was really no certainty. So there was a big randomized trial done in the 90s called the Women's Health Initiative, involving over 16,500 women aged 50 to 79. And this shows results for women who still had their uterus, so they got combination therapy. Estrogen as a conjugated equine estrogen, known as Premarin, and medroxyprogesterone. And they got these, they were randomized to this intervention, and they were followed for an average of 5.2 years. Now, if you look at the upper left-hand graph, you'll notice that the dark lines are placebo, labeled with PL, and this is the intervention group. And you notice that there's a beginning almost right away. You can see that the lines splay apart, and there's a greater risk of developing coronary events, heart disease. We see that there's a greater risk of stroke that happens after about a year. That's quite dramatic. An increased risk of blood clots to the lung, a pulmonary embolism. And there maybe later there is a slightly increased risk of invasive breast cancer. So this threw the whole notion of the benefits of hormone replacement therapy on its head. Another study showed that providing this dual therapy, hormone replacement therapy, as I'm going to call it, actually led to worsening cognitive function after several years, so that there was an increased risk of dementia and there was of developing dementia. This looks at the 3MS 100, which is a comprehensive mini-mental screen. So increased risk of cognitive loss. I guess the good news, sort of the slight silver lining, was that there was a reduced risk of colorectal cancer and a reduced risk of hip fracture, presumably because of the beneficial effects of estrogen on bone. But did the information really give us a valid assessment of hormone replacement therapy? After all, the women were taking urine. I was going to say, we're taking urine, not quite, but sort of. They were taking a compound that was derived from the urine of pregnant mares. That's why it's called Premarin. So is that, does the type of estrogen make a difference? And also, does the type of progestin, they use medroxyprogesterone, make a difference? So was all of this change in culture that came about from the Women's Health Initiative because not real medication that was not human was given to them? Well, we don't know about other estrogens, but we do know that if they did not take the progestin, there were slightly different findings. There were over 10,000 women in the Women's Health Initiative who had had a hysterectomy. And so they did not get the progestin. They were just randomized to either the conjugated equine estrogen or placebo. And there was no increased risk of heart disease, also no increased risk of colorectal cancer. And even though the lines on the breast cancer part look like they're splaying apart, that was not statistically significant. So no increased risk of invasive breast cancer. Also protected against fractures, also increased the risk of stroke and venous thromboembolism, blood clots to the lung. So the progestins did change the response a little bit, but still there were lots of risk factors associated with estrogen use. Now this is a very busy slide, but the bottom line here, let me see if I have is that in the first 10 years, this is sort of a synthesis of all studies that have been done, randomized trials, observational studies, and in the first 10 years, in early menopause, there is actually protection against mortality and protection against cardiovascular disease. That changes. So the hypothesis is that the results from the Women's Health Initiative were due in part because the majority of women were more than 10 years past the menopause. So it's a different biology as time goes on. So we still don't really know what the true effects are on heart disease. Nonetheless, the U.S. Preventive Services Task Force this year basically came out with their own set of recommendations to healthcare providers. Do not prescribe for women who, for estrogens for chronic conditions. Do not prescribe even if the woman does not have a uterus. And the bottom line is that in their opinion, the potential harm from estrogen replacement therapy far outweighs the potential benefits. But we have a lot of questions still. Even though this WHI results, these results were considered definitive by many experts, we're not going to see another, or unlikely to see another super expensive study of the safety and efficacy of different modalities like transdermal hormone replacement therapy. What we've learned is that how we don't know yet, but we think that how the estrogen is derived may matter. What we do know is that scientifically, topical estrogen does not induce clotting factors in the liver, which may contribute to the thromboembolism, maybe the heart attacks, maybe the strokes, we don't know, but possibly. Whereas any oral estrogen stimulates the production of clotting factors. So there are these unknowns that we're not likely to answer anytime soon, because I don't think there will ever be another super expensive, many million-dollar clinical trial like the Women's Health Initiative. And we do now know that it seems that the progestins that are used in combination therapy might make a difference. For example, progesterone, the natural progestin, does not seem to be associated with an increased risk of breast cancer or thromboembolism. So we now move on to testosterone and aging. Guys, this could be you. So, it's a lot of men are afraid that they're going to, that with that developing paunch and want to retain their youthful physique, even make themselves look better than they did when they were young. So testosterone is a hormone produced in the testis of men that travels in the circulation in three different ways. About 44% of it travels as a bound hormone or to a so-called or to a protein called sex hormone binding globulin, sort of up there on the right-hand side. And that some of that sort of shifts off to become free testosterone, but only 2% of testosterone is free circulating at any one time, kind of moving back and forth between the sex hormone binding globulin and to albumin. I didn't show the connection, but there is a connection here to there. More than half is bound to albumin, but both the albumin bound and the free testosterone are biologically active. The sex hormone bound testosterone is not biologically active at all. So 44% is not doing anything at any one time. That's important to bear in mind. So there was a very large prospective studies of European males, over 3,000 men, 40 to 79, and they found that total testosterone fell about 0.4% per year, going to very low levels. This is the total T. You can see how it goes down with age. Kind of makes us guys want to sort of shrink into our seats, doesn't it? And the free testosterone fell even more over time. So the other interesting thing is that free or testosterone seems to be dropping more in men or faster in men now in this decade than it did in previous decades. And that's not really clear. So there was the Massachusetts male aging study looked at over 1,700 men between 1987 and 89, and then they looked at the remaining men in the study, about 1,200, between 1995 and 97. And roughly 10 years after enrollment, you'll notice that the cross-sectional changes with different age groups was lower in the 90s than it was in the 80s. Don't know why. So all of this drop in testosterone has been dubbed the male andropause. If women have their menopause, I guess guys ought to have their andropause. So if you define low testosterone as less than 320 nanograms per deciliter or free of less than 65 picograms per ml, and don't worry about the specific numbers. Different studies use different units of measurement. Bottom line is, if the testosterone is low compared to a young male, by age 60, 20% of men have low testosterone, 30% of men at age 70 have low testosterone, and a whopping half of men at age 80 have a low testosterone. However, the prevalence of symptomatic low testosterone is only 2 to 6%, so not huge. And what do we mean by symptoms of low testosterone? Low energy, depressed mood, muscle weakness, and decreased lean body mass, so more, and then proportionately more fat mass. Osteoporosis, men can have their hot flashes too, low libido, and often low erectile function. The trouble is, all of these symptoms can be produced by disease, and often many of the medications that we use to treat disease. So it's really hard to know if the symptoms are due to low testosterone or not. Low testosterone is associated with a bunch of other medical conditions. The causality is not really known, but it's associated with low type 2 diabetes, high blood pressure, hyperlipidemia, high cholesterol. Any major chronic systemic illness will lower testosterone, linked to cardiovascular disease, the use of corticosteroids like prednisone, and the regular use of opiate analgesics like Norco or Vicodin. The problem is that low testosterone can come about because, or total testosterone can come about because that sex hormone binding globulin that you saw that binds almost half of circulating testosterone drops. And if that drops, then there's going to be less total testosterone in the circulation. So if somebody has a low total testosterone, then we have to check the free testosterone before we can say they're truly low. So there are some benefits to testosterone replacement therapy, TRT, in men who have low testosterone. It increases lean body mass, which is muscle mass. It decreases the fat mass, including that special visceral fat, the deep abdominal fat, deep inside the abdomen, not the pudgy stuff that you push on, which is really associated with cardiovascular risk. It improves libido. In some men, it can improve erectile function, and it can halt or reverse loss of bone mineral density. These results are not universal because, as we talked about, many other conditions can produce poor erectile function, poor libido, and the other changes. But these are potential changes from replacing testosterone. It improves bone. So this was a study of 50 men, middle-aged men who had low testosterone. It was observational, no randomized trial, so they all received testosterone gel. And 6 months later, bone mineral density increased significantly in the spine and in one area of the hip, the greater trochanter. So it does seem to reverse osteoporosis. And these were therapeutic doses to restore testosterone levels to a youthful physiologic level, not super, super high. Well, testosterone has, the traditional view of testosterone as a cardiovascular risk factor was sort of opposite of what we used to think estrogen was. Estrogen we thought was protective, which we found to be erroneous, or maybe erroneous. But testosterone was thought to be a risk factor. Heart disease is more common in men. The majority of men who die prematurely the majority of people who die prematurely from heart disease are men. Persons who are bodybuilders and take androgens, super high doses of androgens, sort of like our former governor, Arnie, the Terminator, have a higher risk of heart disease and stroke. So maybe testosterone is a risk factor for disease. That's been sort of the conventional thinking. But we have cross-sectional evidence, which again throws this notion into question. Cross-sectional studies, a low total testosterone is associated with coronary heart disease. Don't know the cause and effect, but the association is there. Low is worse than high. A low total testosterone is associated with about a 35% increased risk of dying. And it's associated with an increased risk of cardiovascular mortality. So maybe testosterone is actually protective. Does it protect, or is it just a marker of poor health status? So here's some stuff which seems confusing. In middle-aged men who are followed along over time, a low baseline testosterone predicts heart disease mortality, but it doesn't predict having a new heart attack or new incident heart disease. How does that work? So there's some paradoxical information about the causality of low testosterone and heart disease. We don't have any randomized trials of testosterone replacement, so we don't know what it does for incident heart disease. There's nothing equivalent to the Women's Health Initiative. So it's unknown whether testosterone replacement therapy can prevent coronary heart disease. Just don't know. But what about testosterone and physical function? Can it turn this guy on the left into the guy on the right with those bulging pecs, six-pack, and big biceps? Well, if we look at testosterone replacement in men who are healthy but have a low testosterone, here it may not do a whole lot. But let's take a look at the data. In the top panel, we can look at, we can see in the Hildreth study, there were 143 men randomized to get testosterone gel or a placebo patch or gel. And then those in the testosterone group were subsequently randomized to get strength training or just do what they usually do, work out on the remote control. So the results were, compared to placebo, testosterone replacement therapy didn't improve physical functioning at all. They didn't get better in stair climbing, walking speed, with or without. So testosterone didn't do anything more than strength training. Kevorkian looked at 49 men, 60 to 78, low normal testosterone, and they were randomized testosterone or to strength training for 24 weeks. And the bottom line is that there was nothing special conferred by testosterone. So in healthy older men with low normal testosterone, it appears that replacing it does not have any independent effect on function beyond just plain exercise. Well, maybe it might work in people who are getting frail. So there were 262 frail or near frail men based on standard criteria that we now use in aging research. There were about 74 on average. They had low testosterone, and they were randomized to get transdermal estrogen, testosterone. That would have been a problem. And they were followed for 6 months. So there was a significant increase in lean body mass, a decrease in fat mass in the testosterone group, but there was no effect at all on physical functioning, getting up from a chair, gait speed, or balance. And the study was terminated early because there were adverse cardiovascular events. We'll get to that. They did, however, have a little bit more strength in bench pressing and in leg strength than the placebo group, those in the testosterone group. So they might get some improvement in strength if they start out being frail, but not meaningful improvements in daily functioning. Okay, so there are side effects of testosterone that are theoretical. We could get elevation of the prostate-specific antigen, a marker for, or a screening test for prostate cancer. Theoretically could make the prostate larger, make it harder for men to pass their urine. It might induce prostate cancer. It could elevate blood count, which it does, to levels that will start sludging the blood in the arteries and increase the risk for heart attack or stroke. Or there could be cardiovascular complications, and the latter two have been found. In fact, in the Basaria study you just saw in the previous slide, cardiovascular complications occurred in nearly 20%. Now, this is not heart attacks per se, but any heart complication. So an arrhythmia, passing out, chest pain. They had one heart attack, which was non-fatal, but cardiac complications as a lump were 20% more common in the replacement group. And this is hot off the press. This was published in PLOS One, an online medical journal, just this last Monday. So, increased risk of non-fatal myocardial infarction following testosterone replacement therapy in men. This was a large study. It was an observational study, not randomized at all, looking at nearly 49,000 men who were less than 65 and 7,000 men who were over 65 who filled their first prescription for testosterone. This was data accumulated from a large healthcare database in this country. So the relative risk of a non-fatal heart attack within 90 days of the initial testosterone prescription was compared to the risk of non-fatal heart attack in the year preceding the first prescription in the groups as a large. So a comparison, not a clinical trial. But they found that in men under 65, there was almost a threefold increase in the risk of heart disease in those who had heart disease, of having a heart attack in those who had a history of heart disease, but no effect on risk if they had no heart disease. But in men who are over 65, there was a twofold increased risk of heart attack, whether or not they had a history of heart disease. So, watch out. All right, growth hormone. You too, my beautiful women, could look like this. I had to actually read the ad under this, where I got this off the internet. I had to actually read the blurb to make sure this wasn't a transgender person. And who's the guy on the left? You watch those crappy movies? Me too. So, the theme here is get enough, get buff, get stuff, because there are side effects. All right, so quickly to review the physiology of growth hormone. It's an anabolic hormone. It builds tissue in muscle, in bone. It makes in adults, it makes bones grow thicker, not longer. So you don't, in excess, it leads to a condition called gigantism. It actually helps to dissolve fat, and it increases blood sugar. And it works, by the way, through an intermediary called insulin-like growth factor 1. So most of the action on muscle and bone is through that intermediary. IGF-1 is made in the liver as a result of stimulation by growth hormone. Okay. This is what happens to growth hormone with aging. Growth hormone itself is a very short-lived hormone in the blood, so they have to sample frequently, every 20 minutes, to get an idea of what it's doing during the day, and they take an average. But doing this is what happens to it over the years. It is really, really high when people are growing, and then around the age of 30, it's down, and then it continues to go down and down and down, and sort of looks like it's plateauing around the age of 80 or 90, but we have very few people in whom that's been tested. So growth hormone became popular around 1990, when a researcher named Rudman and his colleagues suggested that recombinant, that's human growth hormone, could reverse years of age-related changes in body composition in the ways that I suggested: increase muscle mass, decrease fat mass. By 2004, 30,000 Americans at least used recombinant growth hormone as an anti-aging therapy to restore muscle bulk and strength, although it's got to be taken by injection, just like insulin. Here's a quote made on the web. In fact, nowadays, there are some people who believe they found youth's fountain, a hormone that helps you lose weight, reduces wrinkles, lowers blood pressure, adds muscle mass, increases energy, and actually reverses the aging process. It sounds like a fantasy, but it's actually something our bodies create naturally, human growth hormone. Sounds good. So as a result, we were seeing medical tourism to places like Puerto Vallarta, where men and women go to get their growth hormone injections so they can look like this guy, who probably was photoshopped, but. And you can buy growth hormone on the net. Nice growth hormone capsules. Order some today. But oral doesn't do anything, so FYI. So this is little statistics and epidemiology for you. This is called a forest plot. But I'm going to help you see the trees for the forest. What you really want to look at are those circles. This is sort of the summary of these. So that we have growth hormone only and growth hormone plus lifestyle studies. Lifestyle usually means exercise. And what you'll see is that growth hormone does slightly, but statistically, increase lean body mass. It does what is advertised. Here we have the same forest plot again. Look at the circles. Anything to the left means decrease. Anything to the right of that vertical line means increase. You'll notice that with or without lifestyle changes, it does the same thing to fat mass. It decreases fat mass, so it works as advertised. And now that you've seen forest plots, you've got your sub-certificate in clinical epidemiology for the day. So What about its effect on function? Because it's great to look good, but it doesn't do anything if it doesn't make people function better. So this was a study of 52 men, 70 to 85, randomized to getting growth hormone by their injections or placebo 3 times a week for 6 months. Lean body mass increased 4.3% in the growth hormone group, not a lot. Fat mass decreased by an average of 13% compared to placebo. And really nothing happened in the placebo group. But there was no difference between the groups in knee strength, hand strength, or maximal oxygen consumption, a measure of cardiovascular fitness. Didn't do anything. So these are data on the safety of growth hormone compiled from a bunch of studies. It can cause at physiologic replacement doses. I'm not talking about the super stuff that sliced alone gets, the mega doses. This is replacement prescribed by a doctor. It can increase swelling. People get, anybody ever have carpal tunnel syndrome where you get numbness and tingling in your hands? It causes swelling in that around the wrist, so it causes carpal tunnel syndrome. It causes arthralgias, swelling of breast tissue in men, and may cause insulin resistance, poor glucose tolerance, and frank diabetes, all much more frequently than in people who don't take it. How many, I won't put you in line. I guess I won't ask you who takes DHEA. Can anybody say the full name? Go ahead. What is it? Dihydroepiandrosterone. So if you can say it, you're cool, but if you buy it, you're maybe, read. All right, so why is DHEA popular? Well, it is a hormone it's of all the hormones, it has the largest circulating amount in the body at any time. It is produced primarily in the adrenal glands, but also in the gonads and also in the brain in small amounts. It is metabolized to testosterone, and from testosterone it can become estradiol. So it is the principal source of testosterone in postmenopausal women. So this was a 2-year study of DHEA, a little higher dose in men, a little lower dose in women. There were 60 completers in the male group, 57 completers in the female group, and they looked at body composition and physical performance, so strength and peak oxygen consumption. Remember, that's a measure of cardiovascular fitness. And what did they find? Well, I want you to spend the next 5 minutes studying that slide. Okay, I'll make it easy. So basically in men, didn't do squat. Didn't. Women, for physical performance, didn't do anything. It didn't do anything for most areas of body composition, except it did statistically significantly increase the bone density at the wrist. So with aging, fat mass increases, muscle mass and bone density drop. These changes are accompanied by a loss of strength and physical performance, with a secondary increased risk of becoming frail and disabled. Certain hormone replacement therapies have been shown to halt or reverse some age-related changes in body composition, but estrogen, testosterone, and growth hormone replacement each is accompanied by an increased risk of adverse health outcomes, some serious like heart attacks. So, quick summary. Here, Cliff Notes version. Estrogen replacement with or without a progestin may alleviate the symptoms of menopause and prevent bone loss. It also reduces the risk of osteoporosis. But the risk of long-term oral estrogen plus or minus progestin, depending upon whether a woman has a uterus or not, exceeds the potential benefits. And we just don't know whether transdermal estrogen will have similar safety or similar harm and benefit. Just don't know. Testosterone replacement therapy can, in some men with low testosterone, improve their libido and erectile function if those are not caused by something else. It can slightly reduce fat mass and slightly improve muscle mass and may prevent bone loss and osteoporosis, but it doesn't do anything for physical functioning. It might, in frail men, help to improve strength a little bit, but doesn't improve daily physical functioning. Growth hormone, like testosterone, can reduce fat mass, increase lean body mass. Women, you're in luck because you can use it if you really want to. You can look like that lady in the first slide there. And in healthy older men, growth hormone supplementation has not improved physical functioning, men or women. Well, actually, we know in men, but we can infer women too. And growth hormone, as we saw, can have serious side effects. And I would caution you about these unregulated longevity centers that offer growth hormone treatment. DHEA, well, lots of hype, no demonstrated benefit whatsoever. Good news is it's safe. Somewhat bad news, it's considered a nutritional supplement, so there's absolutely no oversight by the federal government, the FDA, about how clean it is or what's in it. They don't care. And the extra bad news is that it's expensive. So I'd like to part with a quote from a journalist named Liz Jones, a reporter for the London Daily Mail, who decided to see what it was like. She was a confessed user of Botox, frightened of getting old, and really wanted to do everything she could to stop doing it. I mean, that's her at 53 on the left. She looks great. So she was made up to look like her mother at 83, which she did for a day until the latex on her face wore out. And it was quite believable. And at the end of that, she said, no matter how much cosmetic surgery I have, I will become old. It's inevitable. And I think that's true for hormone replacement therapy as well. With that, thank you very much. I'll take your questions. I believe that microphones will be circulating. If you can, speak into a mic because you can be heard by all. There is a, right there on my right. I was going to point my laser at you, but that would be a bad thing.
You know, we hear a lot about bioidentical hormone replacement therapy. Mm-hmm. What's the difference between that and the Premarin? And
well, bioidentical is basically derived from the human hormone by recombinant technology. Basically, they inject the human gene into a bacterium, and then it gets incorporated into the bacterial DNA, recombinant technology, and that the hormone is made in batches of bacterial-filled broth, and that hormone is collected and then given to you. Sounds nice. It is actually, because it's not a foreign protein. The concern is that there might be a little residual DNA from the bacterium of origin, but that's all insulin now. The 99% of insulin is recombinant DNA, so it's human insulin, for example, but made in bacteria. Yes, ma'am. Can't you shout?
I can, yes. After stopping hormone therapy, let's say after several years for menopause, how long do the side effects, how long are they a potential from the hormones that were taken?
That's a very good question. I don't think that data may have been collected by the Women's Health Initiative, but to my knowledge hasn't been published. In theory, we would expect those risk factors to taper away. Conversely, the bad things about loss of estrogen start again. So if one stops estrogen, one will have an accelerated loss of bone mass. Yes, sir. No, you didn't. All right. And I saw your hand up there. I'll get you next. Oh, well, maybe not. Sorry. Yes, sir.
Yeah, years ago, vitamins were the rage, vitamin C, vitamin E, and all that kind of stuff. And then it looks like you folks discovered that people that took a lot of vitamins actually had a greater risk of dying than the people that didn't. And yet, still, we know that vitamin C is good for you, vitamin E, but it seems that that's only if you take them as within the food that they come in. And there are a lot of maybe cofactors, or maybe they come in combination, and that seems to be what's healthy. Am I correct in that?
Yes, by and large. I mean,
Okay.
I think that one exception is vitamin D, that we just don't make enough. But vitamin E is a classic example. Thought to prevent or colorectal cancer, did not.
And so what I wanted to ask you then, so it looks like if you take a high dose of vitamin, the body somehow doesn't use it the same way it does if it comes in naturally. So the things that you discussed today, the various hormones in that, you're putting in the body one hormone without maybe other complementary things. So you see decreases in human growth hormone, you see decreases in testosterone and others, I guess. And if you just supplement with one, how can you know that that's not similar to what happens when you just supplement with one vitamin rather than with all the complementary things? Is anybody looking at that? And I know it's a difficult study when you've got so many things thrown in the mix. Would like your comments.
That's a terrific question, and the answer is no one knows, and I'm not aware of anybody looking at that at the moment. Or at least I haven't seen any published studies of multiple replacement therapies going concurrently. I think you bring up a very important point. We sometimes, as scientists, naively think that that everything can be attributed to one thing, whereas human physiology is extraordinarily complex. And sometimes when we mess with complex physiology in just one point, we can do more harm than good. I think that's a very, very valid point.
My question is, when you're looking at both of these replacements, it doesn't look like either of them, or they both have enough significant risk factors. So is there something else or some other treatment that is being looked at to be more beneficial?
Well, regarding improving lean body mass, maybe reducing fat mass, but certainly improving physical functioning. The treatment that has far and away been shown to be the most effective and was the only one shown to be effective in testosterone replacement studies is exercise, strength training. So physical activity is the best thing. It is the single best therapy that we can do, and we don't have to go to the gym and pump weights all day to get benefit. Brisk walking is enough. That's and some strength training, but not excessive. Right? There is a gentleman in the blue jacket. Oh, sorry.
In one of your observations, you indicated that there was no adverse effect for hormonal replacement in prostate cancer. Can you comment upon the use of androgen deprivation therapy?
That's a very good question. There is no. The question is there the use of replacement in men who are undergoing androgen replacement therapy? That's an absolute contraindication. There is no observed increased risk of developing prostate cancer. In men who have had so-called curative prostate treatment and are not on androgen depletion therapy, there have been some trials and not shown an increased risk of recurrence. The trials are very small. The risk, I think, is high, and would really have to be discussed with, the cancer doctor, the oncologist, and certainly wouldn't be appropriate at all. It would be dangerous for people who are on long-term androgen deprivation therapy. So, however, it doesn't seem to increase the risk of developing prostate cancer. This gentleman, I think, had his hand up. And do you mind speaking up?
That's right. It seems like as we get older, we have a problem with lower testosterone. But also as we get older, it seems like we're taking more medication. And some of the medication side effects cause lower testosterone. So how do you know which? I mean, do I change medications or do I pump up like Arnold?
So the question for those who couldn't hear is, testosterone goes down with age. We also take a lot of medications that can affect testosterone. And that might be one of the reasons or explanations for why between 95 and 97, men had lower testosterone at a given age than they did a decade earlier. Well, I suppose you could stop taking all of your medications and get sick and die and that would, and see if your libido got up before you kick the bucket. That's hard though. But I think that what you can do, and then because of these medications we prescribe Viagra, I mean, it becomes one medicine after another, polypharmacy engendered by treating the symptoms of other medications. One thing is reasonable though, is that these symptoms are not something that you should conceal and shamefully and not tell your doctor. There are sometimes different medications that would be equally or efficacious for the condition you're treating that have fewer side effects, have less likely effects on affecting libido, erectile function, energy, and so forth. So there are sometimes alternatives that the doctor can substitute that might restore things. Okay. Yes. I
think it's
time.
I'll just make it quick.
Yeah.
I started hormone replacement therapy at 53. I'm almost 74. I'm still taking it, but I'm taking a very low dose, and I take it every other day or every other night. Is that still dangerous? Because I feel, based on the studies, that it helps your mood, it helps your skin, it helps your bones. It does a lot of good stuff if you don't have a background of heart disease in your family.
Well, that's a very good question, and this is sort of in that unknown category of stuff. There are beneficial effects. We don't know. I would certainly, just as a general comment, would say that any oral form of long-term hormone replacement therapy absolutely is wrong, is dangerous. Whether the transdermal is safe as well as effective long-term remains unknown because we just don't have data from large studies. I think that for every individual, there is a personal balance or personal scale between benefits and harm, risks that you are willing to take for the benefits that you do or could receive. And if one is aware of the risks and is trying to minimize them as much as possible, and the benefits are meaningful, then that's a personal decision. It's not a wrong thing to do. Well, I think one quick question, then we have to take a break. So how does lifestyle factor into all of these studies? You mean, how does sitting on your couch, eating nachos, watching the Broncos and the Seahawks versus being out there on the golf course when nobody else is there affect things too? I think lifestyle, there was some allusion to some studies, for example, in growth hormone and testosterone replacement, where there were lifestyle changes, usually exercise, physical activity. I think lifestyle is an important cofactor at all times. And I think lifestyle is more important at this point than trying to replace hormones. So that answers your question. So it's now to relieve your urge at the surge, and we'll see you back in 10 minutes. Thank you very, very much.